So let me, start another topic, that is ARIA's isoimmunization. Okay. So these days, I don't know, this Zoom is not, cut off even after 40 minutes. So is it okay? I continue, or should I give a break and then join again? I think that would be nice.
Sir,
The
continue.
break
It's okay,
is
sir.
nice, sir.
Continue, sir.
Sir, continue is better, sir.
Okay, if you are ready to continue, it's no problem for me. Okay, so let's do it.
Yes, sir, ready, sir.
Okay, fine. So mute yourself, all of you, and listen. This is a very important topic which I am going to talk now. This is ARIA's isoimmunization, also known as ARIA's incompatibility, or in some of the textbook they also mention it as a alloimmunization. Okay, alloimmunization. Allo is the term we use for the different member of the same species. And in this case, we have got a fetus and the mother. So they are two members of the same species. That's why we use the term alloimmunization. That is the meaning. Let's move on. Now, this is the most important slide if you want to understand the concept of this topic. So please pay attention here. The first stage is called sensitization. Now, see there, it is called sensitization. Now, what do we mean by that? The fetal RBC, okay, somehow cross the placental barrier and enter into the maternal circulation. The fetal RBC are entering or have already entered the maternal circulation. And we are talking about RH incompatibility. That means these fetal RBC are RH positive RBC, or they have got a D antigen on the surface. Okay, there has to be RH positive. And mother should be RH negative. They should have RH negative status, or they should not have D antigen on the surface. What will happen? If the fetal RBC enter into the maternal circulation, these are like a foreign antigen to the mother. Mother immune system will form antibody against these fetal RBC. Okay, so nothing will happen probably during this pregnancy, because the amount of RBC which have entered into the maternal circulation may be less. That may be the one point. And another one, it depends on which time those RBC have entered. There are different reasons for that, Sometimes the abortion, which occurs earlier than 20th week, that may be the cause of mixing of fetal RBC with maternal circulation. Sometimes even amniocentesis, some of the fetal RBC may skip into the maternal circulation. Okay, sometimes at the time of birth it will happen. So we cannot pinpoint exactly what is the cause for this mixing. But if nothing happens, then at the time of birth, definitely there is a mixing of fetal RBC, okay, into the maternal circulation. Now, what will happen in the next pregnancy? This is important. The mother is ready with the formation of a lot of antibody, and these are IgG type of antibody. They can clearly cross the placenta. So the next baby is also RH positive, and these antibody from the mother will cross the placental barrier and reach the baby's circulation. They can damage or hemolyze the baby's RBC, resulting in severe hemolysis. So this is known as RH incompatibility disease, okay, or also known as hemolytic disease of the newborn. If I only talk about the neonatal life, we use the term hemolytic disease of the newborn, which is caused by RH incompatibility. But at the time of pregnancy, okay, we talk like RH incompatibility condition. Look at this here. What can you see? What can you see here? Yes, anybody?
Fusion of
hydrops.
See there. Look at this baby.
Excessive swelling of fetus.
Exactly. Look at this baby. This is a massive swelling. This is massive swelling or edematous baby. Look at the collection of fluid around the face, even the head, back of the neck. Look at the overall generalized anasarca, you can say. The ascites is also there. In this baby, I'm sure if we check the pleural cavity, okay, or pericardial cavity, there will also be fluid. So this condition is known as fetal hydrops. So to define the fetal hydrops, see here, okay, let me write this for you. Fetal hydrops means two or more body cavities, okay, two or more body cavities of that fetus are edematous, okay, are edematous, means they are having collection of the fluid. So two or more body cavities are edematous. Now, what are the body cavities in our body or in that fetus? Can you name them? What are those body cavities here?
Perineal cavity, pleural cavity, abdominal cavity,
Pericardial cavity.
pericardial cavity,
Very
pelvic
good.
cavity.
Very good. So many answers are coming. Excellent. Okay. So the important cavities here are, there are so many cavities in our body. So let me list the, name of those cavities first for you. Cranial cavity. Very good. Okay. Thoracic cavity, pelvic cavity, isn't it? Then joint cavity. Apart from that, pleural cavity, pericardial cavity, peritoneal cavity. So many different terms are there. But if we talk about the edematous condition, then we are concerning about three main cavities. Those are pleural cavity, pericardial cavity, and peritoneal cavity. Pleural cavity, pericardial cavity, and peritoneal cavity. And the fourth one, though this is not the real type of cavity, this is called as subcutaneous layer or subcutaneous space. That is also hugely edematous here. Look at this baby. The whole subcutaneous plane all over the body is edematous. So this is known as fetal hydrops. And most probably this baby is dead. Okay, most probably, though we cannot say for sure, but there is a high chance of death in this baby. Now, listen again. What is the cause of this fetal hydrops? The cause is severe anemia. The severe anemia, which is produced by this hemolytic disease, is the cause of fetal hydrops. Because severe anemia will lead to heart failure. Heart failure will lead to edema all over the body. And this is known as fetal hydrops. So always take this concept. If your teacher asks, what may be the cause of fetal hydrops? Yes, this is the one which we are talking right now, Rh incompatibility disease. But not only this one. Any severe causes of anemia or severe anemia can lead to fetal hydrops in the baby. Now, let's move on. What is the definition of Rh isoimmunization? Let's talk about this. Now, a pregnant woman, please mute yourself. A pregnant woman has produced antibody to the foreign red blood cells, surface antigen. Now, foreign means is the fetal red blood cells, which are D antigen positive. Then only this condition can happen. The pregnant woman should be Rh negative and the baby should be Rh positive. The husband should be Rh positive. Remember, the father of that baby should be Rh positive. Then only the baby will get Rh positive antigen on the surface of the RBC. So I'm sure everybody know that. Most commonly, it is against those of our current or previous fetuses, but also caused by transfusion of mismatched blood, and that is quite rare. This is very rare. We will give this mismatched blood knowingly. We never do that. If sometimes it may happen unknowingly though, okay? If we neglect, if we do not do cross-matching properly, then this type of thing can happen even by the mismatched blood. Now, what is the pathophysiology of this Rh isoimmunization? So let's clarify on that. Regarding the pathophysiology, the most common RBC antigens are of the Rh system, okay? And the predominant one among them is D, this D. That's why it is known as D antigen. There are some other, let's not deviate ourselves. The important one is D here, okay? So this is also known as D antigen positive. Antibody to RBC antigens are detected by indirect Coombs test. In our prior classes, I already explained this point for you. Indirect Coombs test means only detection of antibody. Those antibody are not yet fixed on the surface of RBC. They are free antibody. This is called indirect Coombs test positivity. The concentration of antibody is reported in the dilutional titer, with the lowest titer being 1:1 and titer increasing by doubling, like 1:2, 1:4, 1:8, 1:16, and 1:32. Now, let me clarify about this, because this is a very important concept. So please listen here. Even in Vidal test, even in ASO titer, all of these are antibody titer. Now, Vidal test is done in which disease? Vidal test. In which disease? Quick answer.
Typhoid. Typhoid.
Excellent. Typhoid fever. Very good. This is typhoid fever. Okay. So now listen here. All of these are a bit of similar type of test. And what is the interpretation? We take the sample from the patient, that is serum. Okay. We take the plasma and we isolate serum first. That serum is having certain level or concentration of antibody. We dilute that antibody. Okay. We dilute. When we dilute it maximally, and still in that dilution, if the test is positive, that means there is a reaction between antigen and antibody. That means the level or concentration of the antibody is maximum there. Let me repeat again. For example, if it is positive in 1 to 32, I will take this as a strongly positive antibody titer in the mother than 1:1, because I have diluted this serum so many times. Still, the test is becoming positive. So, similarly, in Vidal test also, maximum dilution titer is considered as a strongly positive, and in ASO titer also, the higher the titer comes, that is considered very positive. Let's move on. Now, what happens to the newborn? In the newborn, because of this, IgG antibody, okay, they will destroy the RBC, and that can result in hemolysis, and that hemolysis will lead to hyperbilirubinemia. Hyperbilirubinemia, also known as neonatal jaundice. Excessive presence of bilirubin in the blood. This is thus the beginning, though. The most severe type of manifestation is known as erythroblastosis fetalis. Okay, and this erythroblastosis fetalis is the cause for hydrops fetalis here. Now, regarding the mechanism, every student knows this already, but still we have repeated it here. The maternal antibody crossing into the fetal circulation and targeting the antigen positive fetal RBC, resulting in hemolysis. This is the basic mechanism. Severe case will lead to anemia, very pale baby, fetal hydrops or hydrops fetalis, and even death of the newborn. It's quite easy to understand now. Now look at this baby here. The similar type of pictures you have already seen. So this baby is also hugely edematous everywhere. All the subcutaneous tissues or spaces are swollen. So this is a case of generalized anasarca, and most of the body cavities, I'm sure, are also edematous, but they're having a lot of fluid. So which type of fluid is this? Is it exudative fluid or transudative fluid? Anyone? Is it exudative or transudative? Yes, who can answer this? This is transudative fluid. Transudate. This is a case of cardiac failure, which is resulting in edema, and that is always transudate, not exudate. The protein content of that fluid is less than 3. Now, look at this another picture of a baby. Again, hydrops fetalis, and even the placenta is edematous in this case. This is placenta. These are called cotyledons. Okay, cotyledons. They are also shown. Regarding the risk factor of Rh isoimmunization, the fetal RBC enter the maternal circulation transplacentally at the time of delivery, which is the most common. Now, I already explained this point to you. How these fetal RBC enter into the maternal circulation. A different way, but the most commonly occurring during the delivery. Now, what are the other way? See this. A woman is transfused with mismatched blood or mismatched RBC. She is Rh negative case, but we give Rh positive blood in her. This is called mismatched transfusion. So she will definitely develop some antibody against that. And other related risk factors are amniocentesis. What is the meaning of this? Amniocentesis means what?
Removal of amniotic fluid for testing or treatment.
Examination reasons that we get the amniotic fluid towards this.
Exactly. You can say aspiration of amniotic fluid with the help of syringe and the needle. Very good. Centesis means aspiration of the amniotic fluid. And this can be, it is necessary in some of the cases, like we want to diagnose certain diseases. So we can go for amniocentesis, and during that time, there is a mixing of the fetal RBC with the maternal circulation. Ectopic pregnancy is another. Okay? Ectopic pregnancy means the pregnancy is occurring outside the uterine cavity, mainly in the fallopian tube, and there is a high chance of rupture. High chance. There is high chance of development of hypovolemic shock, and during that time, it may mix with maternal circulation. Dilatation and curettage. Okay, dilatation and curettage. So let me write the full form for you, because this is a very important term in obstetrics and gynecology. Dilatation and curettage. And this is the way by which abortion is usually done. Okay, the remaining part of the contents are curated out after we dilate the cervix. This will also can lead to mixing. Abruptio placentae. We all know what is this. Abruptio placentae is a type of antepartum hemorrhage where there is premature separation of the placenta. So there is a formation of retroplacental clot. Okay, it can again lead to mixing up between the fetal RBC and the maternal circulation. And placenta previa is another cause. So what concept you got? Okay, please listen once again. Let me repeat this important point for you. Why there is no or very decreased chances of fetal damage during the first pregnancy. Now, this is the reason here. During the first pregnancy, the mixing has not yet happened, and it will take time for the mother to form those antibodies. That's why first time pregnancy, though the lady is Rh negative, and the baby is Rh positive, nothing will happen to that baby. But from the second time onward, a lot of problem happens. Now, there are certain protective factors from Rh isoimmunization. Okay, so what are those? Now see this. Those protective factors are ABO incompatibility. It decreases the risk of maternal isoimmunization from foreign RBC. Why is that? Because they are destroyed quickly. They don't get time, okay, to mount that, reaction. Now, let me clarify by giving you one example here. If we give, okay, B positive RBC, B positive RBC in A negative patient, A negative patient. Now see that the patient is Rh negative, okay, one thing, and the patient is having blood group A. And what we are giving? We are giving Rh positive blood, but from the B group blood. So this is known as both ABO incompatibility and Rh incompatibility. Now, ABO incompatibility is always more serious than the Rh. Those RBC are quickly hemolyzed by the natural antibody which are present in that person. So there is no time for these Rh positive RBC to mount the reaction. That's why it is known as a protective factor. Naturally occurring anti-A and anti-B, see there, rapidly lyse the foreign RBC before the maternal lymphocytes are stimulated to produce active antibody. So this is the reason. But who will do that? Knowingly, no one. As a doctor, we never allow this to happen. This is known as criminal negligence. If this happens in my hospital or under my, facility, this is my mistake. This should never happen. We're just talking about a theoretical aspect here. Now, for Rh isoimmunization to occur, there are certain requirements. So what are these requirements now? Now see this? All must be present for this condition to happen. So these are: mother must be antigen negative. She must be Rh negative. Otherwise, this condition will never happen or occur. The first important requirement or criteria. Second, fetus or father must be antigen positive. Another important. If they are also, Rh negative, then nothing will happen. Okay, there is no reaction at all. Third, adequate fetal RBC must cross over into the maternal circulation to stimulate her lymphocyte to produce antibody to the fetal RBC antigen. Definitely, if a very small amount of RBCs, entered, probably they cannot mount that increased level or increase nor amount of antibody. Fourth point, antibodies must be associated with hemolytic disease of the newborn. What does that mean? They should cross the placenta and they should damage the fetal RBC. This is known as hemolytic disease of the newborn. And a significant titer of maternal antibody must be present to cross over into the fetal circulation and lead to fetal hemolysis. This is very easily understood. And that's why we check the titer. Remember that higher the titer, okay, more severe is the damage. Let's move on. Now, how to manage the case. This is very important part of the lecture, how we manage a case of Rh isoimmunization. Determine whether there is any fetal risk or not. That is the first thing we need to know. Determination of the fetal risk. How we know that? Fetal risk is present only if the atypical antibody are detected in the mother circulation. Atypical antibody means these antibodies are against the fetal RBC, okay? So they should be present in the mother circulation. And that, how we know that? How we know these antibodies are present in the mother circulation? Which test we do? What is the name of that test? Yes?
Indirect Coombs test.
Coombs test.
Indirect
Coombs
Coombs
test.
test.
Excellent. This is known as indirect Coombs test. Very good. Indirect Coombs test. Antibodies are associated with hemolytic disease of the newborn, HDN, hemolytic disease of the newborn. Then only there is a fetal risk. Antibodies are present at a significant titer, usually more than 1 to 8. So you have already diluted 8 times, still it is positive. That is the meaning. The father of the baby is RBC antigen positive. Then only the baby will be RBC antigen positive. The fetal blood type may be determined by amniocentesis or percutaneous umbilical blood sampling. So these are the different way by which we determine what is the fetal blood type. Okay. These are easy for the obstetrician to do under ultrasound guidance. If the fetus is RBC antigen negative, there is no fetal risk at all. Okay, then we don't talk about this condition at all. Okay, so there is no reaction. No fetal risk is present if, again, similar types of points are highlighted so that you will have a clear concept right now in the class. Now see this. Okay, please pay attention. If indirect Coombs test is negative, there is no risk because there is no formation of antibody. Antibodies are present but are not associated with hemolytic disease of the newborn. Maybe they are too less in amount. Antibody titer is very less. The father of the baby is RBC antigen negative. There's no chance of RH incompatibility. If the atypical antibody titer is less than 1 to 8, then we go for conservative management because the chance of severity is very less. And repeat the titer monthly as long as it remains less than 1 to 8. There is very severe damage to the baby or chance of the damage to the baby. So just keep the mother under follow-up. Repeat the titer every month and look for the titer. If it is more than 1 to 8, then you are concerned. Otherwise, continue the pregnancy. Now, how to assess the degree of fetal anemia? Now, let me ask you one very simple question here. What are the two main problems of RH isoimmunization? Okay, if your teacher asks you question like that, the answers are anemia and jaundice. Anemia and jaundice. Now, anemia occurs because of hemolysis. This is a hemolytic type of anemia. Very easy answer. And jaundice occur when there is hemolysis because the heme component comes out. The heme will go on into bilirubin pathway. Increased amount of bilirubin is synthesized, and this leads to jaundice. So what are the two important points now? Anemia and jaundice. The third one, when there is severe type of fetal anemia, then only there is heart failure, and then only there is hydrops fetalis occur. So these are related things. One small question again. What is the danger of hyperbilirubinemia in the newborn? If it is excessive, why are we worried because of this?
Sir, connect risk agar sir
Deposit in brain.
Very good. Excellent. So you already have that concept. It can cross the brain very easily because it's an unconjugated type of bilirubin. It will stain some of the important parts of our brain, mainly the basal ganglia, and that is known as kernicterus. Kernicterus. And the baby, if that baby survive, a lot of neurological sequelae can occur. Very nice. Now, let's come to our point here. How to assess the degree of fetal anemia. This can be done by serial amniocentesis or percutaneous umbilical blood sampling, which is known as PUBS, or we can do this by ultrasound also. So amniocentesis or percutaneous umbilical blood sampling or by ultrasound. Amniocentesis and PUBS, especially the PUBS. Now it will show you what is the hemoglobin present in the fetus, what is the hematocrit there, and ultrasound will check whether the baby is already swollen, whether the baby is already having heart failure or not. These are the different meaning. Amniotic fluid bilirubin analysis is another one. It indirectly indicates that fetal hemolysis has already occurred, okay, because more RBC, when they are broken, okay, more bilirubin will be formed. So that's the connection. Severe the hemolysis, okay, more hyperbilirubinemia will be there. And this is plotted on a Lilly graph. Okay, we'll talk about that a bit later in the next slide. And third one is percutaneous umbilical blood sampling. This directly measures the fetal hematocrit and the degree of anemia. These are the different way. Now, what is the role of Doppler ultrasound? Oh, see there. So these days, okay, this Doppler ultrasound is very commonly used, okay, we go for, transcranial Doppler ultrasound. Transcranial means, through the cranial bone. Now, what we see there, we measure what is the peak flow velocity of the blood through middle cerebral artery. And where is middle cerebral artery? We all know that, right? What is middle cerebral artery is coming from which big artery? Anyone?
Posterior cerebral artery.
Posterior cerebral arteries are mainly coming from.
Circle of Willis, posterior circle.
In circle of Willis.
Okay.
Basically, middle cerebral artery, it will arise from the internal carotid and it continue to the lateral sulcus, several branches, and to the lateral cerebral cortex.
Okay, so different answers are coming. Okay, so let me a little bit discuss about this and make your concept quite clear here. Regarding the blood supply of our brain, there are two main, set of arteries we have: internal carotid artery and the vertebral arteries. Internal carotid and the vertebral. Okay, vertebral arteries will combine together to form basilar artery, and the terminal branches of the basilar arteries are called posterior cerebral artery. Never forget this. Whereas anterior cerebral and the middle cerebral artery, okay, they are coming from internal carotid side. They are coming from internal carotid side. And then most of these arteries will anastomose with each other and form circle of Willis. They anastomose with each other and form circle of Willis. To make it even, a little bit better explained, the two anterior cerebral arteries are connected with anterior communicating artery. Okay. Internal carotid artery is connected with the posterior cerebral artery through posterior communicating artery. Okay. You don't need to know that much detail here, but I'm just telling you where is this middle cerebral artery present. So it is inside the cranial cavity. So what are they doing now? They are doing the Doppler ultrasound through the cranial bone and see what is the peak flow velocity of the blood in middle cerebral artery. And in fetal anemia, now we are coming to the point. If fetal anemia is severe, okay, the peak systolic velocity rises there, and that can be picked by Doppler ultrasound. Now, how we remember this? Anemia is a hyperdynamic circulation. Anemia is hyperdynamic circulation, and whenever anemia occurs, okay, there is a high amount of blood, collection in the body, and so the peak systolic velocity also rises. I'm just, explaining how you remember, how you connect or correlate the things. Okay, if you can remember without this explanation, it is even better. This is very commonly done these days. Let's move on. Now, what is this, a correlation of peak systolic velocity in the middle cerebral artery and the gestational age? Now see this. This is gestational age. Okay, see there, up to 40 weeks. This is the peak systolic velocity in the middle cerebral artery, which is picked by Doppler ultrasound. And there are two graphs which can be shown here. This red graph and the blue one. So the red, okay, fetus with severe anemia, and the blue, fetus without anemia or with very mild anemia. So this is clearly showing us, the more the velocity, see there, more the velocity means if the graph is going a little bit opposite, that means the severe anemia is diagnosed. So this is the information you get from this graph. Now another one is a Lilly graph. This is the Lilly graph. This Lilly graph has different zone. Zone 1, zone 2, and zone 3. Zone 1 is no or mild anemia risk. Zone 2 is moderate anemia risk. And zone 3 is a severe anemia risk. Now see this. So this is done by, plotting the amniotic fluid bilirubin, in the y-axis and gestational age in weeks in x-axis. So you have to do, amniocentesis, and you have to measure what is the amount of bilirubin there. Okay, this is the unit. This is the unit of that measurement. It is called delta optical density. Okay, delta optical density. So see there. So if we have a no or mild anemia risk, we go for the repetition of the test in 3 weeks. In zone 2, this is a moderately anemic risk. So repeat in 1 week or 2 weeks. And in zone 3, okay, this is a severe risk. So you directly go for intrauterine transfusion or delivery of the baby if the baby has crossed, okay, the 34 weeks of the gestation, because after that the lungs are already matured. So this is the a message which is we get from the Lilly graph study. Now all of you, please look at this slide. What is the most common management if fetal hematocrit is more than 25%? Okay. What is the most appropriate management if fetal hematocrit is more than 25%? So see this, repeat percutaneous umbilical blood sampling if it is less than 34 weeks, and delivery is done if it is more than 34 or equal to 34 weeks. So we redo the test again, okay, if the baby is very premature, because we don't want to deliver baby during the time and the risk is not that very high, okay. But if the baby has already crossed more than 34 weeks, lungs are mature, though the baby is still in the premature phase. Remember that from 34 week till 37 week, the baby is still premature, but there is high chance of survival in this baby. So we go for the delivery. So we'll talk about this so many times in the upcoming slides. Now see this, if fetal hematocrit is equal to or more than 25%, okay. Now see this, if the baby is from 34 to 36 weeks gestation, usually 34 week is highlighted in the book, you repeat the test. You repeat the test. But if the fetal hematocrit is equal to or more than 25% and the baby has already crossed 34 weeks of gestation, deliver the baby. Okay, deliver the baby. That what? About the different type of investigation and the decision how we are going to manage a case of RH incompatibility. Now see that one of the important tests which is done these days is transcranial Doppler ultrasound. And that transcranial Doppler ultrasound is assessing what is the velocity of blood flow in middle cerebral artery. That is called peak systolic velocity. That can accurately diagnose fetal anemia and decrease the number of invasive procedures like amniocentesis and chordocentesis. Amniocentesis means aspiration of amniotic fluid. Chordocentesis is aspiration of blood from the umbilical cord. So we don't need to go for those type of tests if this, Doppler ultrasound is done, nicely. That is the, very commonly done procedure these days. Okay. Now see there how it is done. Okay, just a schematic diagram though. They're doing transcranial, ultrasound means, through the mother's abdomen, of course, because we are talking about the fetal life now, and the, velocity of the blood flow in the middle cerebral artery is noted. Higher the velocity, more severe the anemia. Now let's move further. Let's talk about when we intervene with severe fetal anemia. When is the time for intervention if we diagnose severe fetal anemia in the baby? Now, first of all, we should diagnose whether the fetal anemia is severe or not. That is known by amniotic fluid bilirubin in Lilly zone 3. Okay, in Lilly zone 3 means the uppermost zone, or percutaneous umbilical blood sampling shows fetal hematocrit is less than or equal to 25%, or ultrasonography of the Doppler show increased middle cerebral artery flow. So all of these shows fetal anemia is severe. So we need to go for some intervention. Intervention means some management. We cannot wait any longer. And that is done by intrauterine transfusion. If gestational age is less than 34 weeks, and delivery of the baby if gestational age is equal to or more than 34 weeks. Now, why? The gestational age less than 34 weeks means lungs are not mature. The fetus is very premature. So why to take chance if the facilities are available for intrauterine transfusion? Okay, let's go for that. But once the baby is equal or more than 34 weeks, there is less chance of complication even if the baby is delivered. So let's go for the delivery. Okay, this is the main principle here. And this intrauterine transfusion is done maybe intravascular or intraperitoneal, mainly intravascular. Let's move on. Now, this is one slide which is again talking about the different types of management. Is intervention needed in this situation or not? If the optical density, the delta optical density is 450 in zone 3, fetal hematocrit is less than 25%, or MCA peak velocity is high, should I go for intervention or not? What is the answer?
Yes, sir, intervention, because velocity is also high and hematocrit level is less than 25%.
Exactly.
It's a case of anemia.
Exactly. Exactly. Okay. Just now we talked about that. See that? So just want to check whether you are paying attention or not. See this. This is definitely case of severe anemia. This is a case of severe anemia. Zone 3, Lilly zone 3 graph is a feature of severe anemia. Fetal hematocrit less than 25%, severe anemia. MCA peak velocity high, severe. So definite intervention is needed. Now the decision is according to the gestational age, less than 34 week or more than 34 week. Less than 34 week, okay? Now more than 34 is delivery, there's no doubt about it. Less than 34, transfusion is given because there is too much hemolysis going on. The baby is severely anemic, so intrauterine transfusion is given. Look at the concept here. Many times that will be repeated now, okay? So see that this is zone 3, zone 2, zone 1, okay? So after 34 weeks, delivery. Now, before 34 weeks, we repeat this test. In zone 1, repeat in 3 weeks. In zone 2, 2 week or 1 week. And in zone 3, you don't repeat. You straight away go for intrauterine transfusion. After 34 weeks, go for the delivery in any of the zone. If fetal hematocrit, please mute yourself. If fetal hematocrit is less than 25%, okay, go for intrauterine transfusion. Go for intrauterine transfusion if the baby is less than 34 weeks. If the fetal hematocrit is more than equal to 25%, okay, or more than 34 weeks, or even if the fetal hematocrit is less than 25%, but more than 34 weeks, we need to go for the delivery. Both conditions. We don't wait now. This is a risky case, because further hemolysis can also occur. So why to take chance? Deliver the baby and manage accordingly. This is how the intrauterine transfusion, is done. A bit of schematic diagram though. A fetus may receive a blood transfusion through the umbilical vein in the placenta, and they can do this even before the birth. So our medicine is very advanced these days. Now I'm coming towards the end of this very important topic, and one absolutely important concept is still left behind. That is prevention. How we prevent, the hemolysis in the baby. Now, it is done by giving ROGAM. Okay, this ROGAM is the trade name actually. The trade name of this particular medicine which we give. Now, let's try to know a bit about that. This ROGAM is a pooled anti-D IgG passive antibody. Now see this, anti-D IgG passive antibody that are given intramuscularly to a pregnant woman when there is a significant risk of fetal RBC passing into her circulation. Now, what it is doing, it doesn't allow those fetal RBC to mount, okay, the reaction in the maternal circulation. Means those antibodies, they cannot form those antibodies against this fetal RBC. Okay, if we give ROGAM, if antibodies are not formed, then there is no chance of hemolytic disease in the newborn. So this is the main principle of giving ROGAM. The passive IgG antibody, they attach to the foreign RBC antigen, causing lysis to occur before the maternal lymphocytes become stimulated. You see this? These are the passive antibody, means already passive means preformed antibody, okay? So we give this to the mother. So what happens? Even if the fetal RBC are present in the mother now, these IgG antibody will bind with them and they are removed from the circulation. So they cannot stimulate the maternal lymphocyte to form those antibody which can pass to the fetus later on. This is the main principle. Now, please look at this diagram. It is making the things very easy for you. Here is the maternal circulation. This is maternal RBC. Okay, the different maternal RBC are here, and these are the fetal RBC. Now, these are the IgG anti, RH. Okay, this RH is the antigen, isn't it? Now, what is happening? Just try to understand. This antibody will bind with this antigen. This is RH positive RBC. So this is antigen. This is the antibody. So they'll bind and they'll destroy it. And they'll destroy this fetal RBC before they can cause any problem in the maternal circulation. This is the principle of ROGAM. So RH is RBC surface antigen. ROGAM is IgG anti-D antibody. This is important only in RH negative mother. Okay. RH positive, we don't give it. There's no scope of this at all. And what is the goal? Is to prevent immunization or isoimmunization, we should say. Okay, so this is the important point. And given ROGAM early in the 3rd trimester is important here. If we suspect this is a case of RH incompatibility, or if there is a chance of RH incompatibility occurring, then we give this ROGAM. When it is given. Another important question which is asked to the student. See this. Routinely give this ROGAM, okay, RH negative mother at 28 weeks and within 72 hours of chorionic villus sampling, amniocentesis, or dilatation and curettage. Because there is a chance of mixing of fetal RBC with the maternal circulation after doing these things. Okay, so we have to give this within 72 hours and routinely given to RH negative mother at 28 weeks. Okay, so this is a very important point. It is also given within 72 hours of delivery of an RH positive infant if it was not given before. If not given before. 300 microgram of ROGAM will neutralize 15 ml of fetal RBC or 30 ml of fetal whole blood. Very important data here. So it depends how much fetal RBC is mixed, or fetal whole blood is mixed with the maternal circulation. If you suspect more is mixing, then a bit of more dose of the medicine can be given. Now, another important concept here, please listen properly, is rosette test and Kluwer-Betke test. What do you mean by this? Can be asked as an MCQ question very commonly in the exam. So let me clarify this. Rosette test and Cleaver-Betke test. Now, rosette test is a qualitative screening test for detecting significant fetal-maternal hemorrhage that is more than 10 ml. Okay, it's a qualitative screening test for detecting significant fetal-maternal hemorrhage more than 10 ml. And Cleaver-Betke is the question which is asked to you more than the rosette test. Okay, so let me explain the principle of this. See here. It quantitates the volume of fetal RBC in the maternal circulation by differential staining of fetal and maternal RBC on a peripheral smear. So this can assess whether more than one vial of the ROGAM needs to be given when large volume of fetal maternal bleed may occur, like in abruptio placenta or not. So why we are doing this test? That's the first thing you need to understand. We do this test to know how much fetal RBC or how much fetal blood has mixed with maternal circulation. This is the first thing. So if it shows more amount of fetal RBCs are present there, then we need to give more amount of ROGAM, more than one vial maybe. Okay, so this is the concept. Now, you see this, we are coming towards the end, and at the end you have to take this, take home messages, okay, from today's lecture. This is the mechanism of ROGAM prevention. This is passive anti-D IgG antibody, which is given in the form of injection known as ROGAM. This will lyse the D positive or Rh positive RBC from the fetus before they can mount any reaction with the maternal lymphocyte. This is the important point. So once there is no formation of those abnormal antibody against the fetal RBC, there is no chance of Rh incompatibility disease. Now, routinely, it is given at 28 weeks to Rh negative moms, and after the delivery, if baby is Rh positive, if it is not given first. Okay, special circumstances are chorionic villus sampling, amniocentesis, dilatation and curettage, ectopic pregnancy, abruptio placentae, and placenta previa also, because there is a chance of fetal-maternal hemorrhage. 300 microgram of ROGAM can neutralize 15 ml of the RBC. And we need more than one vial, and that is determined by Cleaver-Betke smear. Okay, Cleaver-Betke smear. This is the important one. Look at here. These fetal cells in the maternal serum are subjected to Cleaver-Betke testing, which appear brighter than the surrounding maternal cells. So these are the fetal RBC. These are the maternal RBC. They appear definitely brighter, and for the sake of understanding properly, they are outlined also. Okay, they are encircled there. So this is how the hematologist will identify it. Now at the end, please revise this table. What are the causes of fetal-maternal hemorrhage associated with red cell antigen, also known as alloimmunization? See that? Definitely this is a revision, isn't it? The question is how fetal RBC can enter into the maternal circulation, or how is the mixing occurs. So these are the pregnancy loss causes, like ectopic pregnancy, spontaneous abortion, elective abortion, and fetal death in any trimester. They can be mixing of the fetal RBC with the maternal one. Procedures like chorionic villus sampling, okay, CVS we say, this is done in the first trimester usually to diagnose any conditions there inside the uterus. Amniocentesis and fetal blood sampling. This is called percutaneous umbilical blood sampling. And other would be normal delivery, very common way, the most common way actually of mixing a fetal RBC with maternal circulation. Trauma, placental abruption or abruptio placentae, unexplained vaginal bleeding during pregnancy, An external cephalic version means rotation, okay, rotation of the presenting part from outside. So these are the special conditions, and in each of them we have to give ROGAM so that the chances of RH incompatibility is prevented in the future. Okay, so this one you can do on your own. Okay, you can do this on your own. So I'm not going to repeat it again because all of these things are repeated so many times in today's class. So with this, okay, I'm not going to start another topic today. Okay, so that will be done in the next class. So I'm going to stop here now. Thank you.